Macrory was appointed as consultant midwife in April 2001. Since then, the service has rapidly expanded in order to meet the multiple needs of a hard-to-reach population. With citywide and broad-ranging responsibilities, the Manchester Specialist Midwifery Service specialises in providing a flexible and creative service to women whose lives are complicated by the issues associated with drugs, alcohol, mental health, homelessness, prostitution and domestic abuse. Prior to Faye Macrory and her team's groundbreaking work with mothers with a history of drug abuse, mothers would have specific intervention from social services and other agencies for the arrangements of the births of their babies. Now new mums can look after their babies under the care of Faye and her team. The consultant midwife, who's also received an MBE for her work, has also set up a HIV screening programme for pregnant drug users, which has saved countless babies from contracting the disease. I'm at the Zion Community Resource Centre to speak with Faye about her pioneering work. Faye, you created the first jointly funded drug liaison midwife post in the UK in 1995, and many services nationally have followed your model of partnership working across health and social care. How do you ensure collaborative responsibility for service delivery?
Well, I think it's a real opportunity for joined up working, because if both partners are funding, for instance, my first post, that means it's joined up thinking. It's half a salary for a full-time response to the client group's needs, and it's also very important in terms of sharing information. In the past, services didn't share information about drug using women because, quite frankly, years ago maternity services didn't use that information to give them a respectful journey. They used it to make their journey even more difficult. But now the fact that we do share information because you're jointly employed, there isn't a problem with confidentiality. And I really do believe, I'm quite passionate about the fact that some professionals in all arenas may on occasion use the excuse of confidentiality not to tackle difficult situations.
The Manchester Specialist Midwifery Service welcome your client group with understanding and respect. Has this change in working practice brought you any real benefits?
I'd like to think that all midwives and health professionals treat women with respect, but sadly sometimes that isn't always the case, particularly in the olden days when people weren't aware of all the issues with complex lives, impacted by drug use. And I really believe that passionately, no matter what situation people are in, that they deserve to be treated kindly, with respect and dignity. Research-based evidence is absolutely vital to medical and obstetric and midwifery practice, but you don't need research to treat people with respect and dignity.
How has involving patients and carers in service provision helped?
I think it's very important to involve service users in all aspects of their service delivery, not just because they're drug using women, but because we want to give women-centred care. For drug using women and their families, quite often there's some other complex issues that impact on their ability to engage with services. We try and look at the wider aspect of their whole life in terms of the social care. We very much have a social care approach. Occasionally, women, what they want from services doesn't always go with what they actually may need to sustain the changes needed to be made to take their babies home. But I consider over the years that many women will seek us out. I know they will now, which must say something about being involved in our care, and we're very, we don't beat around the bush in terms of the choices they may have to make. Their choices may reflect some of the choices I as a professional have to make. They're not a good choice and a bad choice, they're a bad choice and a worse choice. And that, of course, is reflected in when we have to involve social services in trying to make some meaningful changes to their lives so they can take their babies home. And many of them do parent very successfully.
I was scared of social services, thinking, oh God, they're going to take them off me, I'm never going to see them. And then when I got put in contact with Faye, it wasn't as hard or secluded as I thought I was. I wasn't the only one in that boat, there was plenty of other women. I've got 3 children now, and I know if it wasn't for Faye, these wouldn't be here, without a doubt.
Who are the other groups you're actively working with, and are you really working together?
I've lost count of the number of agencies that we are involved with, either for a long time or short time. We get a lot of multi-agency referrals, so we may get the same referral from 4 different, areas, including from the woman herself. And very importantly, I think, we're able to give an example of how statutory sector, that is the NHS, works in partnership with voluntary sector. And voluntary sector of many, many professionals with their areas of expertise for the client group that we work with. And I suppose everybody knows us. I've been around a long time. And I make a point of, when I'm making a connection with other agencies, that I invite myself along to their meetings or to their forums so that I can explain what we can offer. It was really important for me to get the money for this space when it became vacant, because I could see, particularly with the appointment of the health visitor, how we can expand our focus onto the children of drug and alcohol users and those who are also socially excluded with problems, so that we can attempt to I suppose, break the cycle of drug use in the family, despair, poverty, and so that they can have a happier, healthier future. So I think that's really, really important in terms of, it's not about more research into the impact of drug and alcohol use of the parents on the children. We know what that does. We want to know, and the government does support, what interventions work. That's what we want to know, and that's what we want to focus on, and that's why we want to develop our package of care here to be meaningful.
Faye, let's talk about the complex issues associated with your job.
Since 1998-99, a recommendation from the Department of Health that all women should be offered an HIV test. So we put a training programme in place for the midwives before they would discuss HIV with women, because obviously that means they've got to talk about sensitive issues like sex, which midwives aren't historically very good at, surprisingly enough. And since then, and the development of this role and the appointment of the HIV specialist midwife on my team, we now have a very robust citywide programme of antenatal HIV testing for everyone, where we actually offer everybody one. And at any time in their pregnancy it can be repeated. Because very, very importantly, years ago when I did the retrospective audit, many of the drug using women had been tested for HIV without their consent, without their knowledge, quite frankly, just because the staff thought because they were drug users they would be bound to be HIV. Indeed, MASH, the Sexual Health Project, started off years ago in response, or was part of the response to a comment made by the Chief Constable at the time that prostitute women were a cesspit of HIV and a reservoir of infection. So indeed, in the last few years we've got an increasing number of positive women. As more people are being tested, we're trying to ensure that everybody is tested at any stage in delivery, obviously without coercion, but explaining that the test doesn't make you positive. It actually, we can find out you're positive, and we can offer you medication in pregnancy, and importantly medication for your baby when it's born. And over the last couple of years, all the babies born to HIV positive women that have tested positive, none of them have contracted HIV because of the success of the programme. Obviously nothing's 100% foolproof, but we're working towards that.
Domestic violence is currently high on the national agenda. How has this impacted on your work?
Nothing sits in isolation, and for instance 50% of the caseload at any one time of the drug and alcohol using women, particularly drug using women, are in violent abusive relationships, which brings in the issues of domestic violence and abuse. And of course, many of the women we work with, particularly at street level, are vulnerable to being groomed by inappropriate older men and the issues that come with that. And sometimes we have to be very clear about thinking the unthinkable and occasionally having to say the unsayable. So it's terribly important to get an accurate and in-depth history of the partners of the women, and what other names they may be going by. Of course, not everybody has a complex past, but the vast majority of people in drug treatment services, it's a chronic relapsing situation, and they've been using drugs for many years before they reach drug treatment services. Again, anecdotally, and we're trying to collect some more evidence in terms of our data, is that 70 to 80% of women coming through drug treatment services have been sexually abused at some time in their past, in their adolescence, and continue to be re-victimised by working on the street or in sauna or massage parlours. And of course we've got the increasing problem of trafficking and the violence that goes with working the beat, and that has huge implications for those of us delivering care in the maternity services and gynaecology services in terms of the vulnerability of the women, and midwives and doctors being very aware of the language we use, the equipment we use. You know, one woman said to me, the soft words of the midwife remind me of the way the abuser spoke to me. You know, so it's not to turn people into experts in that field, but it's to make staff aware that if a woman becomes very distressed, it may be coming from somewhere else, and we don't want to, you know, add to that re-victimisation by our procedures. Many women, when they've been using drugs for a long time, that's their coping mechanism. If we take that away, we've got to offer them something better if they're going to stop using. Many people are stable on methadone and don't use anything else on top. And certainly in pregnancy, we don't advise being drug-free for the first time in many years at the point of delivery. In fact, I think that's irresponsible for workers to even suggest that. A, it's an unrealistic goal, but B, put the woman in a very vulnerable situation in terms of the stresses of caring for a newborn baby, and also her own vulnerability to, if you've been drug-free for a short period of time, you have a huge potential for risk of overdose should you suddenly decide you want to start using again. Or, of course, if some of your friends encourage you to start using again. Because giving up drugs quite often means giving up all your friends, giving up where you live, you know, because drug dealers will soon seek you out if they know you're trying to give up. When you're begging your friend to give you some heroin, women have told me they won't share it. But when you're looking healthy, you're trying to give up, you know, they're jumping out at street corners offering you it free. A little bit like, I mean, some people who smoke, I don't smoke, but when you're trying to give up, friends don't throw away their cigarettes and say, what a fabulous idea. They say, oh, go on, Alf, go on, Alf. And the same is mirrored in the drug using population, because quite often looking healthy, happy, doing things that the person who's still heavily using would like to, it's actually easier to try and encourage your mate to join in than to try and get to where that person is. So those are all the complex issues we work with.
What has been the overall impact of your groundbreaking work?
I like to think that women now feel welcome coming through the doors of maternity and other women's services, and that, you know, they turn around and say to me, Faye, I don't get treated like dirt anymore, and that's a good outcome for me. And that they actually turn up. We have some women who will turn up even when they're not pregnant, and the midwives now welcome them, give them a cup of tea, rather than perhaps calling security as they used to in the past. And perhaps that particular woman that I'm thinking of will not be able to engage in terms of making a huge difference to her alcohol or drug use, but because she now feels welcome, perhaps 5 years down the line she'll be able to engage in a treatment programme, because it's a long time. Change takes an awful long time, and at the end of the day, many of the women who come through our door need a pat on their back for where they've got to. They don't need us as health professionals with the power of our uniform and of the hospital to you know, make them feel worse about where they are. Women have said to me, Faye, I don't need to be made to feel any more guilty than I already do. And most of them, instead of having a prescription for methadone, actually need a prescription for a new life and a different past. Who I am on occasion talking to is not 29-year-old Sandra. Who I'm really talking to is 12-year-old Sandra, who's taken from a home of abuse, put in social services care where she had further abuse. Then she found drugs, which were great. She never felt so good. And then she's been frozen in time, emotionally and intellectually, for the last 12, 13, 14 years. And then we expect, you know, people just to be natural born parents. So, you know, there's a lot of information that I do share with staff, which is, I think it's appropriate in terms of them understanding, you know, about the difficulties of women's lives. And that actually the information the women share with us is, you know, it's privileged information, and we must treat that information with respect. You know, and care in the past, and perhaps in pockets elsewhere, shouldn't be based on your moral view of people's lifestyles and what they use or what they do. It should be based on good practice and research-based evidence. You don't need research to treat people with kindness and dignity, particularly at such a vulnerable time in their lives. Many of the women have been involved with social services care, as I said, and they're terrified that their children will be taken off them, even though we try and reassure them otherwise. But if social service have to be involved, we're very frank, and we work as an advocate on their behalf to help them make some sustained changes so that they can parent happily and safely.
Faye Macrory, thank you.
Thank you.